All right, so we're gonna go over more OMI stuff today. So we're gonna start with a short story to introduce my topic today. It's CCT. It's 10:50, uh, 10 minutes before shift change, and a patient rolls in with chest pain. You get this EKG, and you're with your seasoned attending. Seasoned attending looks at it, goes, initiate transfer for an anterior STEMI. And your senior resident, it's at that time of the year where they tend to talk back, especially on high risk patients. And he says, "Hey, maybe this is just LVH restrained. Maybe we should hold back on transfer." And Dr. Sinna goes, "Shh, be quiet. Do a point of care ultrasound to look for some wall motion abnormalities." So before we go, tell you what happened to this patient, we're going to go over some LVH EKGs, kind of like a very difficult EKG that's tortured me and many attendings for decades. So this patient had this LVH. You get very high voltage EKG, and the reason why it's so problematic in interpretation is there's a lot of abnormal depolarization, which causes abnormal repolarization, which results in a lot of ST elevations, ST depressions, and T wave reversions that can look very ischemic. Uh, and the problem with LVH is that it is actually excluded in the traditional ST elevation MI criteria. So you can get pushback on from cardiologists. Hey, this is LVH. We can't use STEMI criteria. So let's go over kind of LVH, acquired LVH. Usually a problem with either outflow or a volume problem. So most commonly, it's a problem with high blood pressure. We see a lot of this pattern in our patients because we have a lot of uncontrolled hypertension in our patients. But other things to think about are kind of valvular problems, regurg, stenosis, and what results pathologically is you get more mass. And the problem with more mass is that you get more voltage, more action potentials, and it messes up with your vector, your net vector on EKG. Additionally, your heart sits in your chest wall, and your heart's bigger. It's closer to the surface of your chest wall, so your precordial leads are closer to your heart, and that can also increase the voltage on your EKG. And the voltage can be so large that they can touch in your precordial leads. And does anyone know what the sign is called? Yeah, this is Siemens sign. You can't make this up. Uh, it's a very sensitive. It's a poorly sensitive, but we don't really care about sensitivity because if it exists on EKG, then that's what matters, right? On you know, occult LVH, not very important to us. We just have to identify LVH on the EKG and kind of assess whether the secondary findings of all these ST segment changes are significant. So here's just another example. You have touching QRS complexes concern for LVH. Another example here. Here you actually notice some left atrial enlargement. You have a kind of a wide biphasic P wave in V1 and right atrial enlargement, tall P waves in the inferior leads, which just kind of supports your diagnosis of LVH. So like I said before, LVH changes your net electrical vector. Do you guys know how it changes? It goes left, mostly left. What else? I don't know. I only discovered this, but go left and posterior and slightly inferior. Only so slightly inferior. So which leads do you think would have really tall R waves, like a mostly net positive, based on the changes in your vector? V6, it's a lateral lead. What else? So let's see. So one, definitely very lateral. Two, maybe. What else? AVL, yeah, definitely. And maybe since it's slightly inferior, you might get tall R waves in AVF. Um, what about like a net negative S waves? So the opposite of these leads. AVR definitely. So AVR is the opposite. It's very right. What else? Yeah, V1, V2. So instead of posterior, you're gonna have negative. You're gonna have positive in posterior and negative in anterior. So V1 through V2, maybe some V3, depending on just the shape of your heart. So here you can see tall R waves in one, V5 and V6. AVL actually looks okay here, maybe even an elevation. And here you can see deep S waves in, sorry, tall R waves in, sorry, AVF. What else? Then deep S waves in V1 through V3, and a deep S wave in AVR. So the ECG criteria for R waves, I kind of just, it's 11 and 12 and one in AVL. Sometimes these are the only findings you may see on the EKG. And AVF, I often mislook, but it's greater than 20 millimeters. I feel like this is the less common finding on for LVH. So here you definitely can look at the one is greater than 12. AVL is actually not non-existent, and AVF is greater than 20. So this patient has it. LVH. There's some S wave criteria. What I use is something that was taught by a resident to me, but it's actually pretty good diagnostic value. It's called Pegro-Lopresti. Basically, if you look at the S wave in V4 and any S wave on the EKG, and if it's greater than 28 in males, it's pretty diagnostic for LVH, and 23 for females. So here you see, if you calculate it out, I can just eyeball it. It's probably greater than 28 millimeters. There's one lead that's already greater than 28 millimeters. So this is probably LVH.
How many big boxes is 28?
Big boxes would be 5 times, so 6, about a little less than 6. There's also something called, so the more criteria you have, the more likely the patient has LVH. And they've had like these bunch of different criterias. We've talked about Siemens. There's also a Sokolow line, which is what I use too. It's basically you look at V1, V2, whatever is deeper, you add it to V5 or V6, whichever is taller. If that's greater than 35, then likely have LVH. Not very sensitive either, but pretty good specificity. There's also something called Cornell criteria, which we're not going to go into because I feel like this is enough to diagnose LVH. Also, there was a really mean attending who would grill me on Cornell criteria, so I just don't use it anymore too. It wasn't no longer employed by our great institution. So
It's the scale on y-axis when you're looking at EKGs at King's, and I think the Siemens sign is like for the standard.
yes,
So you can change like how tall the waves look in order to like get a better sense of morphology. And I'm pretty sure it's like 1 millivolt per 10 millimeters per millivolt.
yeah, you could change the calibration. One important thing I forgot to mention in that study, they looked at EKGs like this. So there's 12 leads and 1 rhythm lead. When you get the printout, that's what it looks like. But when you look on Muse, it auto switches it to 3 rhythm leads and squishes it together. And you can't use that. You have to switch it to a 1 rhythm lead, or you'll overdiagnose LVH. Okay. You can. So there's a button on the bottom that gives you a bunch of views. You can get a 1 rhythm view. You can get all rhythms you can get rhythm strips for all 12 leads, which I like to do. If there's a lot of motion artifact in 1 lead, then I'll just get the 12 lead. Then I can find that some good non-motion artifact parts of the rhythm to. Right. So right now, basically, I just eyeball it now. Before I did count it because it's not so much to diagnose LVH, but we'll go later. Is when you have these two-way inversions, do you think can these be attributed to LVH? But if LVH is not present, then maybe that's concerning, right? So here is just another, I guess, patient had Siemens and they have the V1, V2, V5, V6 criteria. Same EKG. So basically, I actually do the reverse. So this is kind of my algorithm. Hey, could this be possibly LVH? This is a really high voltage. There's a lot of ST segment depressions, inversions. Then I go through the combination criteria. And if those aren't fulfilled, then I kind of eyeball the R waves and S waves, whatever I find easier to fulfill, I use one of those criteria. It's like a kind of a 2-step criteria. So here, just some practice EKGs. Do you guys see overlapping QRS complexes? Maybe here, but I'm not gonna. This is only 1 beat. What about the second criteria? Yeah, so you look at V2 and V5. It's greater than 35 millimeters. So this patient has probably LVH, and there's a lot of inversions here. So maybe those are secondary to LVH. What about here? So no overlapping QRS complexes. What about the second one? Yes, yeah. So if you add, I think V2 and maybe V5, V6 look pretty much the same. It's greater than 35 millimeters. All right, what about here?
Yeah.
Yeah, pretty. It's good. Don't think too hard. These are touching you. Your guide to LVH. All right. What about here? Do the combination criteria are they fulfilled? Where's my mouse? No. So let's go into the second criteria, the R wave criteria, because I see some tall R waves. Yeah. So you just need one. So this is the one looks greater than 12, and AVL is greater than 11. So probably patient has LVH. Honestly, when you're looking at this EKG, there's not many T wave inversions in ST depression, so you probably don't care. You probably wouldn't even look for LVH here. But this is just for practice. All right, so this one you might care a little bit. So you have a lot of ST stuff going on, but any combination criteria fulfilled? Yeah, so you see overlapping QRS complexes. You see tall, I mean, one is like over 20 millimeters, AVL is over 20 millimeters. A lot of LVH, great LVH fulfillment here. But the question, in this type of EKG is this EKG ischemic? What do you guys think? Yes or no? No. Patient has came in for chest pain. We don't know. I mean, I get this EKG like 20 times a shift. It's tough, right? You got to see the patient. But we'll go over to this. Go over it. So there's non-voltage criteria of elevation. That's the stuff that gives us like anxiety and keeps us up at night. So this is something called LVH restrain, which is kind of misleading. So, but why do we care? Like I said, LVH causes ST wave abnormalities. If it can cause, STEMI criteria, it can fulfill STEMI criteria, which is kind of annoying. And you have to ask yourself, can you attribute these ST findings to LVH, or is this ischemia? So how I taught why there is a strain pattern when I was a resident was that your heart's so big it causes subendocardial ischemia from just the mass from pressing against pressure, and I got a lot of troponins for these patients, and I found out that's incorrect. It's actually you have severe abnormal repolarization. The more abnormal depolarization you have, the more abnormal your repolarization. So it has nothing to do with ischemia, because all these patients come in for toe pain, foot pain, just incidental findings. So how that works is kind of like left bundle, but not quite. Basically, wherever you have deep S waves, downward QRS, you're going to have ST elevations. So opposite directions. When you have tall R waves, you're going to have ST depression. And technically, the deeper your S wave, the taller your ST elevation, and the taller your R wave, the greater your depression is. And when those don't really fill that pattern, that should kind of raise some red flags. So here you see a lot of ST elevations, but they're all with kind of really deep S waves. Here you can see ST depressions, but really with really tall R waves. So my gut instinct here is this is probably LVH with repolarization abnormalities and not a ST elevation MI. If you look closely, there's 1 millimeter elevations in 3 in AVF and ST depression in AVL, which are reciprocal changes, right? So you could interpret this as an inferior, even an anterior. It's kind of a weird distribution. Someone with crushing chest pain, they diaphoretic, maybe you do call it because it's, the LVH strain pattern isn't really can't rule out an MI.
One thing that might help you if you're lucky and have it is to look at old EKGs. And so if you see an old recent EKG that looks the same, that makes you feel a little better. Doesn't mean if they're having chest pain, you still will get the enzyme if they're having chest pain, but that makes you feel better. The other thing, just I wanted to mention that run the LVH in V1 and V2. Can you go back to the last one? Often you may have poor R-wave progression. It may look like an old anterior septal MI or recent anterior septal, but that's part of the LVH as well, that poor R-wave progression in V1 and V2. But again, if they're having chest pain, you don't know if that may be a recent MI.
All right, so just another example. This one's a little bit more difficult, but I think this is a real case, and I probably may have sent this patient home. But this is a ST elevation, but in a really deep S wave. And here you have some depressions with tall R waves. This one's a little bit, if this patient depends, you really got to go by clinical presentation because this ST elevation does look pretty big, and these ST depressions look kind of flat unless strainy pattern, which we'll go over. Just another example, I see this pattern a lot in tachycardic patients with LVH. This can be misinterpreted as AVR ST elevation with diffuse depressions. Is this a left main occlusion, or is this patient just dehydrated? So it's very difficult to kind of assess here, but you do see a lot of ST depressions with tall R waves and ST elevations with deep S waves. All right, so let's talk about morphology. So in LVH restrained pattern, typically the ST elevation is concave upward and not convex, not tombstone. The T wave, if you really look into it, the T wave is asymmetric. The slopes are. It's kind of slow uprising and then has a sharp takedown. And the elevations can be greater than 1.5 to 2.5 millimeters. And you typically see the elevations kind of in the anterior leads because that's where your S waves are the greatest. ST depressions are kind of similar in that they're kind of curvilinear as well. Almost look kind of biphasic, and the T waves are asymmetric as well. And you either may get this pattern here for all your leads. You may get this something called an atypical pattern where it progresses, kind of have curvilinear upward, and it kind of goes downward, even flat, and then it goes really down here. Caleb? Yeah. There's something, or like a chronic or end organ damage from like CKD and stuff. But you can't really be asymptomatic in hypertension. Type 2, probably. All right, so here's another. This is just a good example of the atypical progression. Here it's almost looks kind of flattish, and then it just goes downward. And this can be really tall airways. This can get really deep. All right, so LVH restraint pattern recap. So you have deep S waves with ST elevation, tall airways with depression. The ST segments are typically kind of curvilinear and concave. T waves are asymmetrically sloped. And you cannot diagnose a strain pattern without LVH on EKG. All right, so if you have a strain pattern without LVH, it's probably not strain pattern. It's probably bad. Some caveats: your QRS has to be less than 120 milliseconds. Then if it's greater, then you start thinking about a left bundle. You can't diagnose LVH in the left bundle because the conduction in the left bundle is atypical in the left bundle. So because you go down your right side and then you have cell to cell depolarization on your left. So it doesn't go through the traditional depolarization through the bundle of His to your left bundle to your left anterior fascicle or your left posterior fascicle. So you can't diagnose in left bundle. You can't diagnose in WPW because you have this kind of a similar problem where you're actually you have cell to cell depolarization of LV as well. So you can't diagnose in WPW or any abnormal LV conduction. Sometimes in the left anterior fascicular block, you can have false positive LVH findings. But you can diagnose in the right bundle because your conduction is normal. Some differential diagnoses can be like early repull, patient's really thin, they're an athlete, they have hypertrophic cardiomyopathy, or just have whatever electrolyte derangement can mimic LVH. So let's go over LVH with OMI. This is why we're here. So why is it difficult to distinguish LVH from OMI? It meets STEMI criteria. Common patterns of OMI can be normal in LVH. Normal patterns in strain pattern can be OMI and LVH, and patients can often present similarly. So like I said, this could easily be interpreted as almost like an inferior anterior MI. But I'll give you 3 or 4 tips on things to look out for. So tip number 1, you have excessive discordance. It's when the ST elevations or depressions look a little bit too deep for the how tall the R or S wave are. So you can use, I know in Scarbosa you use like a 25% ratio. There's some literature looking at 15%. Um, and one, it's really hard to, sometimes it's hard to measure. Like Tobias said, you could change the kind of the calibration of the EKG to half standard to kind of measure out the leads. But how I look at it, if the one big clue that this may you have excessive discordance is when your tallest SC elevation isn't with your deepest S wave, or your deepest SC depression is not with your tallest R wave. And we'll go over some examples here. So here you have excessively discordant ST elevations. Especially what really catches my eye is actually V5. You have 2 to 3 millimeter ST elevation with their S wave is only like 10 millimeters, so that's about 30%. And here, if you really calculate out, these are all greater than 15%, and this person had an LED occlusion. Another thing that Dr. G mentioned before is technically in a LVH you should have a tiny R wave if you really zoom in your anterior leads. These are all Q waves here, and V1, V2, V3. So it's just something some clues to look out for. Here's another example. I think if I was in a busy pod shift with 40 patients and I just looked at the lateral leads, maybe this is LVH and just think this is LVH, but really you gotta look, this is your tallest, deepest S wave. There's not even ST elevation here, but your tallest ST elevations are in the inferior leads. So this is an inferior STEMI. So don't miss that. So this patient, you can have LVH restraint and an inferior STEMI. You can have them together. That's the beauty of emergency medicine. Yeah. So tip number 2. So this is the left side is strain pattern morphology, but in an MI you may have symmetrical looking T waves, and instead of having concave upward ST elevations, you may have convex ST elevations. So here you also have kind of high voltage, touching precordial leads, but if you look at the lateral leads here, very dome-like tombstone. You guys shouldn't miss this. Please don't miss this. This person probably had an LED, a pretty big LED or left circumflex OMI. Here's another example. I think this is a real case, maybe an NSTEMI case. But here you notice that instead of having the like curved SC depression, these are all straight and they're all very linear, right? And if you really look closely, maybe there's some AVL elevation, and this is probably a very subtle like high lateral MI. And I can't remember the cath report, but this was an OMI. So another tip is that if you have any concordant SC elevation depression, what does that mean is if you have SC segments that go in the same direction as your QRS complex. So if you have SC elevations with tall R waves, or you have SC depressions with deep S waves, it's like kind of like Scarbosa, as those can be concerning, but they can also be some other diagnosis like early repull, which also very problematic to diagnose at MI. So here you see a couple things that are concerning for MI. You have LVH criteria you met through like I think V2 and V6. You had those scale that's greater than 35. But here this looks excessively discordant, right? This SC elevation is almost 5 millimeters, and the QRS is only maybe 15 millimeters, 10 millimeters, so 50%. But if you look over in V4, you kind of see concordant ST elevation. Which is confusing here is there's also this notch right here, this early repull. So you can easily mistake this for early repolarization. But if you notice the morphology, this is a fishhook. So you have this terminal positive end of the QRS, but there's none here actually. This is also called, you guys know what this is called? This is QRS distortion, terminal QRS distortion. So this is a very difficult EKG because you have LVH and early repull. It's just a nightmare to diagnose an OMI, but this patient had a LED occlusion. I think you guys kind of see a pattern here. Next EKG, LVH definitely here. What's abnormal is, what do you guys think? So if you're so don't get distracted by this. Although this should also distract you, and that this can be concerned for what type of MI? Posterior. So the ST segment also very very linear here, and there's a tall R wave in V2. So now let's doesn't go with the LVH pattern. You also see the kind of inferior ST elevations. So yeah, carousel, yes. Kind of looks like a carousel. I don't have the picture. I think I had it on the prior EKG, but yeah, it can. I'll send it to you guys later. It's hard to explain. So tip number 4, T waves. You can look at the T waves that in ischemia. They can be very broad. They can be symmetrical. It's hard to explain like with words. So I'll show you some images. So here you see kind of these fat T waves here, and if you were to really draw some lines and measure out the slopes, they're kind of symmetrical. And this is you have some almost biphasic as well here, excessive discordance maybe, but this is a very deep S wave. But this is kind of concerning for Wellens, kind of a Wellens type pattern. Yeah, by kind of deep S waves. This T wave is almost as deep as the S wave in this lead, and these leads are probably the most concerning to me. And I think this patient had LAD stenosis. Here you see really wide T waves in the setting of LVH, kind of in the same leads here and in the fear leads. This patient had kind of not an occlusion, but they had really bad stenosis of their LAD and RCA. All right, so we've got some time here. So we're going to go over some EKG. These are just half EKGs. You're going to tell me if A or B is ischemic or both. And you got to tell me why. Or is that just stall? The resident just stall. B, yeah. What in B makes you think? Yeah, so very linear depression here. Kind of dome-like ST elevations. There is LVH with 1. It's greater than 12. What about here? Not concerned.
Like in these, you're on B.
On B, okay.
It's like quite small.
Exactly. So this is out of proportion, yeah. Yeah. So your ST elevation is out of proportion to your S wave. But this morphology is very concerning. So you guys are right. B is concerning for ischemia.
Can you go back to that one? Oh.
Yeah, I'm back. Yeah.
Yeah, the other thing is, not only is that an inferior MI possible, and they're even trying to get Q waves there, but 3 is so much higher ST elevation than 2. I would also worry about the possibility of a right ventricular infarct.
Exactly.
That's so impressive.
And then I think Graf mentioned there's some concordance in lead 2 here. AVF, yes, concordance. So bad. This one probably LVH pattern, very tall R waves with this curvilinear ST depressions here. All right, next EKG. B, Y. Also very concerning for proportionality, morphology, right? Not very curvilinear, and it's out of proportion as well.
Would you call to AVF hyperacute? Or like, I guess 2-3 AVF?
These are definitely hyperacute T waves, but also
I mean,
ST elevations too. Yeah. So very tall compared to the QRS complex. It's like these are like tombstone, essentially. Yeah, exactly. Yeah, that's the. What are you about A? Not impressed? Send back to the waiting room. You're in pivot. No, you guys don't do that yet. Yeah, this to me looks like very similar. It has decent kind of fits the LVH pattern. What about here? A or B or both? So B, some people say B. What's concerning about B? Sorry, these are all yeah, these are not precordial leads. Yeah, yeah. So yeah, so if you notice in V2 that this is the kind of the greatest depression, it's actually in a very small QRS complex. This should raise suspicion for a posterior MI because typically in LVH you don't have tall R waves in V2 and V3. You have deep S waves. So you can have this in RVH, which we won't go into, but the degree of SC depression is kind of alarming to me. What about here? This is also alarming. This for a posterior MI. So, so also, I mean, this is almost equivalent to this, but this QRS complex is half the size of this one here. But again, this fits LVH in these leads, but this doesn't really fit LVH. You have tall R wave, V2, V3. Next EKG. A or B? A, what's going on with A? Oh yeah, this one kind of gives you away, but this yeah, so there's the SC elevation is going in the same direction as QRS complex, so this is by itself very concerning for MI. Here maybe, but and a little bit here, but also that you have this linear ST depression, and the also concerning for posterior involvement. So probably posterior lateral, inferior to the lead two here. You guys are worried about this one here? Yeah, this one's actually LVH with early repull also kind of giving you a headache, but we'll go over early repull next time. But yeah, to me, this is a fine normal EKG. Not normal, but not enough to diagnose an MI. What about this one? So I hear A. Anyone think B? B. Yeah, so that's actually a really good point. So the textbook said this is fine, but they do acknowledge V3 is abnormal because this ST elevation almost looks out of proportion to to the QRS. So if this patient had chest pain, I would consider, sending a troponin. There's no, I think this pattern here, this pattern here is probably a kind of LVH pattern. What about A? Yeah, so just compare it to this one over here. The ST depressions are very linear. So, I mean, this is not enough to diagnose like a STEMI, right? But this is concerning for maybe at least subendocardial ischemia or reciprocal changes. Where? Oh, here? Uh, maybe, but not like the one you think in the hyperkalemia because it's upright. What about this one? A, yeah. What's bad about A? Yeah, concordant elevations. Don't think too hard. So yeah, there's tall R waves. They're going in the same direction. So V3, V4 probably, and V5 is probably like a kind of a bad anterior MI. Um, it's a good thought, but that you in the QRS distortion, you actually see like kind of the S wave. Here it's completely obliterated, and this is just like the STEMI, yeah. What about B? Yeah, I think this is probably LVH, but not enough to get me to trigger an MI, like a STEMI alert. What about these? This one's actually a pretty tough one. This textbook say. Which one? B. Why B? Oh, that's it. I missed that one. Yeah, that's a good call. So out of proportional SC depression, kind of linearly almost, and also here you kind of have depressions in the wrong leads, right? I mean, yeah, there are tall R waves here, but there's also deep S waves, so you think maybe it would be isoelectric. I'm not sure, but the morphology in these leads are concerning. What about A? Not enough to. I agree. This is actually someone with hypokalemia with LVH, so this is why the T waves look kind of domey here. Uh, so just a reminder that two pathologies can happen at once. See. and B. It is. This is hard to tell. Yeah, would this get me out of? If I didn't have any of this, would this get me out of my seat? Probably not. Maybe there is some depression, but it's not enough to make a huge decision on. All right, what about this one? B, yes. Who said B? Dr. Center. What's wrong with B? I hope you guys can identify. Look at these depressions. They're massive. There's like 10 mm depression. Uh, so yeah, very concerning for MI. Even in V3, you can think about a posterior MI. Here, what about here? Super high voltage. It looks proportionally okay, right? Um, so A's okay. What about this one? A or B or both? Tombstone and A's, definitely MI. What about here? Yeah, so also kind of out of proportional depression, discordant depression. If you were to calculate it, it'd probably be greater than 15%. Um, but just looking at this, very deep. These R waves are similar, but this one is significantly deeper than V5. Yeah, exactly. Good call. So I don't even have to look at this. This is concordant depressions, very concerning for MI. What about here? This textbook has a good sense of humor. It's probably where the SC elevation is. Too. A or B? What do you guys think? Yeah, this one's tough. I mean, I don't know if you could call a STEMI on this, but the morphology is V1 is not curvilinear, right? It's almost dome-like. Here you have Q waves here instead of like the R. Q waves in V1 as well. And this SC elevation is pretty tall for the S wave. So this one looks like typical LVH pattern, and this could possibly be an MI. Any do I have of these? Quick, A or B? B, good. Don't need to explain. What about here? B, yeah, so definitely out of proportional ST elevations and the anterior leads. I think you guys are getting a hang of it. We're almost done. Yeah, A again. So you also notice a lot of QAs here. Uh, and also the morphology is not quite curvilinear, but the ST segment is pretty straight. So that's kind of concerning for MI. Here is almost it's convex here. What about this one? A or B? Let's look at A. Are these normal T wave inversions for LVH? I don't even know if LVH is present here. It's not. So what's going on? Yeah, this looks like someone who had an MI. Maybe this is Wellens, but this is some elevation, so it's very concerning for an anterior, maybe a late presenting MI. Here to me looks kind of like LVH pattern as well. It's good proportionality. Do two more and then let you guys go. See, what do you guys think about this? Someone said B. B. What's going on with B? Yeah. What about the morphology? It's kind of not curvilinear. Here it's about to get convex. Uh, and here you have depression and I think this is mostly, I mean, they're pretty equal, but uh, in kind of it looks almost concordant. So B definitely ischemic is enough to make you trigger STEMI, it's up to you. This fourth year is going to be attending soon. It's going to be your decision. See. All right, this will be our last one. Then I'll skip the rest. Because I'm getting tired. See. A, yeah. What's wrong with A? Yeah, exactly. So the morphology, also a lot of Q waves in V1 through V3. But this is concern for an anterior MI. This one, I think the proportionality is adequate for LVH. Yeah. Look, I think that's fine. Technically, you don't meet it, but the morphology is concerned. There's a millimeter elevation V2. Yeah. I don't know. You don't have any information. Nurse just gives you the EKG. You're examining another patient. But this is probably someone I would get out and say, hey, maybe I should go see the patient. All right. So let's end this lecture. So LVH with OMI recap. I hope you guys learned something, but things to look out for: excessive discordance, concordant ST changes, look at the morphology, look at the T-wave morphology. Clinical presentation matters, and you just have to accept that there's no way to perfectly distinguish LVH with strain with LVH with OMI. So back to our case, got our season attending versus fourth year resident. He gets the point of care ultrasound. What does he see? Sure, maybe some septal akinesis. I guess you can't really see it that well. You see dissection flap. Yeah. So you get this patient on Cardine, Esmolol. Maimonides calls back. Attendant picks up the phone. He goes, I'm actually transferred for a type A dissection. Mama goes, okay, can you send it to CD? He's like, no problem. We actually have something better. We have point of care ultrasound. All right, send the patient over. Patient gets disposed at 11. The great thing about being attending is when you're 100% wrong, you're still 100% right. So I got this sign out, very clean sign out. So thanks, Rich, for that. Yeah.